welcome to one more symposium and meet the expert of the 39th Vicenza course. We have the pleasure to host, sponsored by BAXTER, Professor Sean Bagshaw from Alberta, Canada. And he is going to speak about the clinical prediction of persistent AKI, assuming that there is a new biomarker called CCL14, also known as nephroclear. And without further ado, I will ask Sean to start his presentation. He's already sharing the screen. So please, Sean, you can start.
Thanks very much. Welcome. I'd first like to thank Baxter and their team for the opportunity to contribute to this symposium. Second, I'd also naturally like to thank Prof. Ronco for the opportunity to contribute to this, the 39th course on AKI and CRT. And then finally, I'd like to thank Prof. Prowl for his moderation of this session. So I look forward to discussing clinical prediction of persistent AKI, novel application of C-C Motif Chemokine Ligand 14 or CCL14. I have these disclosures for 2021. So let's begin by briefly discussing managing acute kidney injury, the known knowns. First, we know that acute kidney injury is common in critical illness. Second, we recognize that AKI in critical illness is often, if not usually, multifactorial in nature. Third, we know that AKI can often occur in the context of multiple insults occurring concomitantly or over time. Fourth, abundant evidence has shown clear association of AKI with increased morbidity and mortality. And finally, we know that a single episode of AKI, even mild AKI, can contribute to new risk of CKD or rapid progression of end-stage kidney disease. So let's focus a little bit on patterns of recovery after an episode of AKI. This large database study of close to 17,000 critically ill patients with stage 2 to 3 AKI described 5 patterns of AKI reversal, with recovery defined as reversal occurring by the time of hospital discharge. Importantly, the risk of 1-year survival was substantially varying across these phenotypes of recovery. So here you can appreciate the varying risk in survival through 1 year by AKI reversal phenotype. The best outcome being those who had sustained early reversal, the worst among those who never reversed. However, there is still a substantial difference in the other 3 phenotypes: late sustained, relapsing reversal, and relapsing no reversal. Importantly, in the 4 phenotypes with the worst prognosis for their survival, it would be helpful to have tools to better predict their clinical course and perhaps prescribe clinical care and management accordingly. So now let's perhaps focus a little on the known unknowns about managing AKI. As we have just shown, the clinical course of an episode of AKI can be varying and unpredictable. This is due to a wide spectrum of patient susceptibilities, exposures, and treatment-related factors. Some might argue even critical care itself. This is an important knowledge gap because currently we have no reliable means to predict the trajectory of AKI across a wide spectrum of presentations. And we have no reliable means to predict the probability of early reversal and recovery versus relapse, persistent, or no recovery. In the end, this contributes to uncertainty in clinical decision-making, particularly for interventions that have important risk-benefit profiles, such as renal replacement therapy, and arguably even has negative implications on clinical decision-making. Examples for this could include A, starting renal replacement therapy early in a patient who has a high likelihood of early reversal and recovery without ever needing renal replacement therapy, or B, withholding renal replacement therapy in a patient with a high likelihood of persistent AKI, where the relative hazard of AKI is greater than that of initiation of renal replacement therapy. There is evidence of this uncertainty, particularly in the START-AKI trial. We designed START-AKI to be pragmatic and real world. As such, we aim to seek individual clinician equipoise as part of the eligibility criteria, recognizing and acknowledging that there is clinical uncertainty that many clinicians are confronted with when deciding when to initiate renal replacement therapy. However, we noted that a significant number of patients who were eligible for START-AKI were excluded due to the lack of individual clinician equipoise. Indeed, this represented about 89% of all exclusions of patients who fulfilled provisional eligibility. As part of START-AKI, we captured a limited data set on those patients excluded due to a lack of individual clinician equipoise. So of those excluded, because patients perceived RRT deferral was mandated, only 11% ultimately received renal replacement therapy, and their mortality was around 25%. Alternatively, though, in those excluded due to clinicians perceiving immediate RRT was mandated, 91% ultimately received RRT, and their mortality was much higher at 47%. I would argue that these observations reinforce the relatively wide uncertainty clinicians have for predicting the clinical course of AKI and the likelihood of either recovery and/or worsening AKI that would prompt renal replacement therapy initiation. It has long been promised that novel biomarkers and diagnostic tests may help bridge this knowledge gap, enable personalized approaches to care by providing insights into the individual AKI trajectories, and further aid clinicians in decision-making at the bedside. What do we currently know about novel biomarkers? Well, prospective studies provide evidence that selected biomarkers can identify patients who are at high risk for developing AKI. Selected biomarkers have also been evaluated in RCTs to predictively enrich populations by identifying and enrolling those at high risk for AKI to specific therapeutic approaches or interventions. And biomarkers have also been evaluated as tools for clinical decision support for when to initiate renal replacement therapy in critically ill patients with AKI. However, the strength of evidence precludes their routine use for this indication. So herein, I'm going to describe the discovery and validation work for the novel biomarker urinary C-C Motif Chemokine Ligand 14, or CCL14, to predict the occurrence of persistent severe AKI. This was the discovery study, the RUBY study, and the objective was to identify candidate biomarkers of persistent severe AKI. The design was prospective, multi-center, observational in design. The study population included 364 critically ill patients enrolled within 36 hours of fulfilling KDIGO stage 2 AKI. Blood and urine were sampled and candidate biomarkers were identified from a large spectrum of candidates. The primary endpoint was persistent severe AKI, and this was defined as patients with KDIGO stage 3 AKI at enrollment that persisted for greater than or equal to 72 hours, patients not at stage 3 AKI at enrollment, but who reached stage 3 AKI within 48 hours and then persisted there for more than 72 hours, patients who reached stage 3 AKI but died within that 48-hour window, or reached stage 3 AKI, did not reach, who were at stage 3 AKI less than 72 hours, but received initiation of renal replacement therapy or subsequently died. The secondary endpoints of interest were a composite of renal replacement therapy or death, or MAKE-90. In total, 1/3, about 33% of patients developed the primary endpoint. So urinary CCL14 was found to have the best prediction for persistent severe AKI with an ROC of 0.83. Urinary CCL14 also outperformed all other individual and combination biomarkers tested, as you can see here on the figure on the right. Urinary CCL14 was also shown to enhance the predictive ability over a baseline clinical model using logistic regression, which included variables such as BMI, diabetes, non-renal Apache 2 score, AKI stage, and serum creatinine trajectory. So this improved the ROC from 0.89 to 0.89 from 0.85. Further sensitivity analyses, modifying the definition for persistent severe AKI, so using windows of 24, 48, 72, 96, and 120 hours, showed robust and consistent performance. In addition, all biomarkers showed elevation with persistent severe AKI, but unlike the other biomarkers, urinary CCL14 showed consistently lower levels across comorbid conditions. So this would suggest that marked elevations in urinary CCL14 were specific to persistent severe AKI. And you can see this outlined nicely in the table. The occurrence of secondary endpoints, the composite of RRT or death, was greater with increasing tertiles of urinary CCL14, as shown in both these figures. The figure on the left showing major adverse kidney events at 90 days, whereas the figure on the right showing mortality alone at 90 days. For example, mortality increased from 32 to 63% from the first to the third tertile. Notably as well, the majority of the clinical events that occurred within the first 30 days. As such, the RUBY study provides preliminary evidence that urinary CCL14 may provide novel diagnostic and prognostic information for clinicians to aid in bedside decision-making, and for things such as the timing of initiation of renal replacement therapy. However, these findings necessitated further external validation. So to externally validate the RUBY study, we performed a secondary analysis of urinary CCL14 using data from the multinational SAPPHIRE study. In this, our objective was to externally validate CCL14 to predict the development of persistent severe AKI. The population was comprised of 195 critically ill patients within 36 hours of fulfilling KDIGO stage 2 or greater AKI. And again, we banked samples for blood and urine within 36 hours of onset of stage 2 AKI and prior to the initiation of renal replacement therapy for patients enrolled in the study. Urinary CCL14 was measured using immunoassay on the NephroClear CCL14 test on the Acute 140 meter, and analyses were similar to that performed in the RUBY study. The primary endpoint was persistent severe AKI, defined as KDIGO stage 3 AKI for greater than or equal to 72 hours, using both serum creatinine and urine output criteria. The secondary endpoint was a composite of renal replacement therapy initiation or death through 90 days. So as you can see in the figure on the right, of 195 patients who were eligible and enrolled, 14% or 28 patients developed persistent severe AKI. We found the ROC to predict persistent severe AKI in the SAPPHIRE study was 0.81, which was very similar to that found in the RUBY study. And you can see this actually illustrated in the figure on the right. Moreover, we further showed that urinary CCL14 added incremental value to the baseline clinical model using logistic regression containing serum creatinine and non-renal Apache-3 score. Sorry. The ROC in this increased from 0.77 to 0.83. We further showed in simulated analyses of varying baseline prevalence that the risk of persistent severe AKI increased with increasing values of urinary CCL14. And that's nicely illustrated in this figure here. You can also see in this figure, we confirmed that higher tertiles of urinary CCL14 portended greater risk for the secondary composite endpoint of renal replacement therapy and or death at 90 days, with the greatest risk occurring amongst those who had the highest tertile levels of urinary CCL14. This finding was found to be robust in further multivariate analyses, including treating urinary CCL14 as a time-dependent variable. So as you can see in the table, all models using CCL14, both as a continuous and when comparing tertile 3 to tertile 1, were significant, suggesting that there was strong association between the urinary CCL14 level and the probability of renal replacement therapy and or death at 90 days. So what are the clinical and research implications? Well, I would argue that urinary CCL14 has the potential to add clinical information to guide bedside clinical decision-making. For example, a negative test may reassure clinicians that recovery is imminent and that a watch and wait approach is likely suitable. So if there was contemplation of initiation of renal replacement therapy, this would help inform or justify, if you like, a watch and wait approach. Alternatively, a positive or strongly positive test would identify high-risk patients for persistent severe AKI and then could inform triage decisions So for example, admitting patients to an ICU or a high dependency unit for monitoring, strategies to mitigate the occurrence of AKI complications, dose adjustment, withholding nephrotoxic medications, etc., or other interventions that might reduce the risk of downstream CKD. Importantly, in my view, urinary CCL14 can be used in clinical trials of novel therapeutics and approaches to management of AKI to predictively enrich the study population with those at the greatest risk for persistent severe AKI, and ultimately give us new and robust evidence about how best to move forward with the management of this difficult dilemma for clinicians. So in summary, urinary CCL14 may be an important mediator of kidney tissue damage and appears to be a robust indicator of risk of maladaptive repair and non-recovery of AKI. It has good predictive performance for future development of persistent severe AKI in independent external validation, discovery in the RUBY study, validation in the SAPPHIRE study. Urinary CCL14 would appear to have incremental value beyond common clinical variables alone in predicting the occurrence of persistent severe AKI. And I believe it may be a new tool to help inform clinical decision support in critically ill patients with AKI. So this is something that can be used in conjunction with clinical judgment and other clinical variables to help inform decision support for how to manage patients with AKI. And with that, I will thank you for your time, and I hope we have some opportunity for discussion and questions. As mentioned earlier in the presentation, the urinary CCL14 is measured as the NephroClear CCL14 test on the Acute 140 triage meter. Thanks very much.
So thank you very much, Sean. And this also gives me the opportunity to introduce John Prowell as a co-moderator of this short symposium. Before I give the word to John for a few questions, I would like to make a comment and see what Sean thinks about it. First of all, I would like you to slightly expand a little bit about the mechanism of CCL14 as a molecule. And then I would like you to comment on the fact that this biomarker substantially puts the question on hold about late or early application of CRRT, because it seems that you finally have the tool to avoid futile therapies on one side, applied too early. On the other hand, you have the possibility to apply early correct therapies and not to watch and wait too much. So can you comment on these two aspects?
Yeah, two comments then, Claudio. Thanks very much. So the proposed mechanisms for CCL14, I'm not sure we've fully elucidated all the nuanced mechanisms by which CCL14 acts both as a marker and maybe a mediator of kidney damage. But it's believed in response to damage, levels of CCL14 are secreted, and higher levels reflect higher degrees of sort of inflammatory damage to tubular epithelial cells. It's possible that CCL14 then acts as a chemokine that recruits additional inflammatory milieu to the site of injury, monocytes, T cells, et cetera, that compound or magnify the degree of injury over time. And so this would be another mechanism by which you'd magnify tissue damage. So high levels of CCL14 may in of itself recruit additional inflammatory mediators that propagate damage and will put you at higher risk for the clinical association, which would be severe persistent AKI.
Do you have any hint if these levels of CCL14 correlate in any way to the type of recovery?
I don't have that specific data on absolute levels of CCL14 correlating with courses of clinical recovery, as I presented earlier on in the presentation. For instance, those 5 phenotypes of recovery, it would be very fascinating to see if we had CCL14 levels that correlated with these clinical phenotypes of recovery patterns. We don't have that data yet. It may be plausible that we have bank samples in one of these sort of prospective studies where that could be investigated. But as far as I understand at present, we do not have those data. To address your second question, Claudio, the use of CCL14 as a potential biomarker to help inform clinical decision support around the initiation of renal replacement therapy. So I'm going to be honest, it looks promising, and it might have been something that we would have tested in a pilot trial before we implemented START-AKI, recognizing that that was 10 years ago that we were designing that trial. It does look promising. So I think clinicians, even in START-AKI, we know that clinicians had a fairly reasonable degree of uncertainty, and many lacked equipoise around starting or not starting. And so part of the issue to me would be if we were to put in the hands of clinicians a reliable and robust biomarker that had been validated that says, look, over the next 72 hours, this patient either is not going to recover or is going to have persistent severe AKI, then you may be able to use the other clinical information available to you to weigh the pros and cons, the risks and benefits of initiation of renal replacement therapy in that context. If you were to say, look, this patient's really sick, they're on a ventilator, they are on vasoactive support, they've got non-renal organ dysfunction, I think the risk of AKI here is really high. And you know what, renal replacement therapy, now that I know it's going to persist for sure, renal replacement therapy might be something that ultimately benefits this patient. And it might help trigger and inform that decision. That's how I envision this kind of test being used at the bedside. I don't think this test can be used simply as a one-off, positive or negative, and a yes/no decision-making. It has to be integrated with all the other clinical information.
John, it's now your turn to ask a few questions.
Very good. So, well, you've already covered a lot of the interesting areas that I had. But and first of all, I'd really like to congratulate Sean on the tremendous presentation, both of the amazing results from START-AKI and of obviously these more interesting new results from the biomarker studies. But really, it's fascinating to connect these two pieces of work together and think about how we move forward in this field. But I'd like you perhaps to begin to reflect back on START-AKI and this group of the way in which physicians view their patients, because overall the impression I get from what you described about the patients where they didn't feel they had equipoise was actually the physicians are performing pretty well, and they were good at identifying patients who were quite sick. They were good at identifying patients who were well. However, our current tools, either by the basis of what the physicians thought or on the basis of the AKI diagnosis, weren't effective in helping us give better therapy to the patients in the middle. So, I mean, is that your kind of view from START-AKI, that actually doctors are quite good, but they need help in cases where they don't know what to do?
Yeah, like, part of the rationale when we designed the trial was, we recognized, and we tested this in a pilot study, was that, clinicians, do integrate all the information available to them at the bedside. So if you have a critically ill patient on a ventilator, some vasoactive, with sepsis, getting fluids and resuscitation, and has non-organ dysfunction and AKI, you might be able to see over the span of 6 or 12 or 18 hours their clinical response to your interventions. And so in a patient who's rapidly recovering, vasopressors coming down, urine output's gone up, despite the lag in serum creatinine, and maybe they have stage 2 AKI at that time, you probably have some prediction, some pre-test probability that these patients are likely to recover. And in those circumstances, you may forego initiation of renal replacement therapy and say, I'd like to watch and wait. So I think one of the things that some of these tests or moments in time don't give us is that opportunity to observe the response to interventions. The alternative is true, though, if you have a patient who is getting worse over that period of time, or is persisting with just needing pressors on a ventilator, persistent organ dysfunction. Those are patients who maybe you have a little less certainty about. And in this circumstance, it's likely that a lot of clinicians said, I don't know, but I think they need it. And once they mandated its initiation, well, there was nothing really we could do about that in the trial. What we really tried to do was, the Goldilocks phenomenon in the middle. Those patients who had, were basically in the ICU, on a vent, on pressors, pretty sick, high organ dysfunction, and AKI that was effectively there. do you know what's going to happen? And if you don't, then there should be equipoise around whether you initiate renal replacement therapy or not. But we found that there wasn't for everybody. And so this is where I see a test like this potentially coming into the fold and saying, you know, I don't know what to do with this patient. Should I start? Can I wait? En masse, Start AKI might say, maybe you can watch and wait for a little while longer and you know, start initiation of renal replacement therapy when complications of AKI start to evolve. However, now I think we have this opportunity to prospectively validate or prospectively evaluate biomarkers such as urinary CCL14 in the context of that scenario again, to say, okay, look, should we start, should we not, in this, you know, sort of gray zone? Because I think starting too early, clearly in Start AKI suggested maybe that's not to the benefit of patients. But we've also seen in Acute 2 now that if you start too late, if you wait too long, the hazards associated with untreated AKI start to outweigh any potential benefit you may get from renal replacement therapy. And so I think this is where urinary CCL14 is probably going to fit in the middle, at least in this context in ICU. Yeah.
Sean, would you consider CCL14 would have been extremely helpful in the COVID-19 pandemic situation where different centers went short of equipment and treatments? Isn't that true?
I actually think there could have been some real clinical value to having a test like this to provide some decision support around this. We saw, and the reason I'm going to pick on John a little bit here, but you know, the ICNARC data is some of the most robust data we have on critical care and COVID in the world. And it's really interesting to show the patterns of behavior that occurred with organ support in the first sort of, I'd say, first two waves, John, and then the subsequent two waves. So in the first two waves, wow, the attack rate of 25% of all critically ill patients being supported with renal replacement therapy was massive and concerning and alarming for many people. Why was that? We're not sure. Was that true AKI? Was that treatment to help with, you know, gas exchange and fluid overload? We don't know. At the same time, in the third and fourth waves, that, you know, attack rate of renal replacement therapy, so to speak, dropped to what, 12 to 14%? So some learnings had occurred between those waves and over time. Now, it's possible there could have been other variables changing, new therapeutics, new variants, new approaches to care, not sure, probably. But would a test like this have been helpful to help, you know, support or refute a decision to initiate renal replacement therapy in selected patients who had severe COVID, ARDS, and on a ventilator? Possibly, right, John? What are your thoughts?
My thoughts are that it's fascinating to think back on how we would use tests like this in the past and in the future. My personal feeling about any test like this is this sort of Bayesian approach that you've described, that if you just measure this test and then you look at it and you say, well, what does that mean? It doesn't, it's not an insightful way to use it. You've got to evaluate the patient. You've got to think about the patient. You've got to decide which camp you're in. You've got to do the Start AKI kind of evaluation. And then you do the test. And sometimes you'll look at the test and say, oh, well, the test and what I thought don't coincide there. Maybe I've got to go and reevaluate my assessment of the risk. Sometimes you'll be reaffirmed in your decision. And sometimes you'll say, look, the test is a bit elevated there. And actually, this patient may have some sustained AKI. But look, the context is actually one where we could still wait for a little bit. Okay. And so the test would then be used intelligently and also be used intelligently within your resource allocation and things like that. Reflecting back on the pandemic, I think very early on, there was some behavior to do with maintaining very negative fluid balances that could have precipitated worse AKI. I think that the use of anti-inflammatory drugs has actually positively impacted on the incidence of renal replacement therapy. I don't think we just saw these rates in the UK, we saw them in New York and other places like that with similarly kind of mixed outcomes. But there's a lot of learning from these episodes that we have, and actually more information that we can integrate in decision making is really hugely valuable. And I think of this test, I don't know, you might reflect on it, and in comparison with other biomarkers, that it's another kind of window onto the soul of the kidney at the time. We're talking about what information is going on in the kidney as reflected in the urine. but the cellular processes that we think are involved are ones that are going to be quite sustained. These are not transient processes like cell cycle arrest. These are processes involving cellular infiltration that are not going to turn around very quickly. And so we've got a sort of biological insult here, which correlates with the findings that we have, and therefore kind of brings us into a sensible clinical pathway. And that might even be that that we think that renal replacement therapy is a bridge too far in some patients. You know, it might be, oh well, I'd give a little bit of renal replacement therapy just to treat this metabolic abnormality in a patient, but I don't want us to get into a sustained period of renal replacement therapy in this patient who's got a potentially very poor prognosis. So there's many different ways you could use this test in different prognoses and different clinical situations, I think. But it's very interesting to reflect on that. But I am very interested to think about going back to the context of patients in the past. We've seen the context of patients in your study, the patients in other studies, the patients in Acute 2, and how they would have been filtered if they'd had this test available to them. It's fascinating, and I think my feeling is that there is a wealth of research to be done to examine these, translate these hypotheses into clearer clinical guidelines.
Sean, we have 20 seconds left. Do you want to make your final statement?
Well, first of all, thanks to Baxter, thanks to you, Claudio, for the invitation to present today, and John, again, for his moderating. I do think that in the next weeks, months, years, we're going to see new data on how CCL14 can be integrated into clinical decision-making and clinical practice. I would very much like to see it integrated into predictive enrichment in clinical trials, to therapeutic regimens or care processes. So I'm hopeful that we're going to see a plethora of data that shows how this is actually a valuable biomarker that can help inform clinicians in the care of patients with AKI. So that's my summary.
So thank you to Professor Baxter, thank you to Professor Prowl, and thanks to Baxter for sponsoring this. And let's go back to the scientific program of the 39th Vicenza course on AKI and CRRT. Thank you.